when we are sharing our screens and stuff. Okay. Jamie, good afternoon. How are you?
Good afternoon. I'm doing well. I'm excited to be here, although it is rainy, which is never very much fun. So I think we should have fun here.
Absolutely. It's cloudy and wet and cold, and we understand that. By the way, I just got reminded cold weather is coming. And I learned from Dr. Kemp today, who you will be seeing just very shortly, that this winter is the time for space heater burn. So please be careful about using space heaters. But on a more positive note, it's the diabetes month coming up and the World Diabetes Day on November 14th. So I think there's a bunch of good things happening.
I agree. I think, and just a preview, we're putting together some cool small content, some blogs, and a small Facebook Live on like what can you do during Diabetes Month. So we've got that coming. Just a little teaser. But we've got viewers starting to join us. I see there's a few people streaming in. So just as a reminder, say hello, let us know that you're here, and tell us what part of Iowa you are watching from. We do want to hear from you through this entire broadcast.
Absolutely. All right. Well, we will get started. I mean, this is something serious we're going to talk about today. Did you know that diabetes is the leading cause of non-traumatic amputations in the nation? Like after trauma, this is the next one. And the good news about all of that is it's very avoidable. And today we will have an expert who will talk about that. So we'll kind of talk about the common foot problems, how to monitor to make sure you are not at risk, and then how to prevent these things from happening. That is the plan today. As my introduction, I'm Anuj Bhargava, endocrinologist, interested in diabetes since 1994. And Jamie, you have met as well, RMD professor at Drake, very passionate about diabetes. But I think to really tag team, and by the way, we got a good day from Altoona from Carla and Arnold. So welcome to the group here. And again, please tell us your name, where you're from. That's always appreciated. So today, to talk about feet and soles, we have Dr. Ellen Kemp. He joined Des Moines University Foot and Ankle Clinic as assistant professor in 2021. He previously was in Pennsylvania, where he did a residency in podiatry, and the emphasis was on foot reconstruction, Charcot's, which is a very feared complication of diabetes, and also saving limbs. Yes, diabetes is the leading cause of non-traumatic amputations, but with a good team, we can really reduce that incidence. So hello from Holly and from Connie as well. All right, so let's bring in Dr. Ellen Kemp. We'll be standing together. Thank you so much for joining today.
Thank
and
you
here
so
we are.
much. It's a pleasure to be here.
Excellent. All right, we'll move back like this to see if we can. And it's really you who need to be. So we'll play this together.
Yeah. So
begin and see.
Yeah, really excited that I think you guys are good. I can see both of you. I am excited to see some new names come through, and excited to see some of the same people as well. So Holly, Connie, thank you. Cindy, thanks for joining. So we're hitting some different parts of Iowa. I love it. I love that we're hitting all over. So maybe in Oskaloosa, you are not seeing the rain that we are seeing here. We do have a poll to get us all started. So let us know. Type in A, B, C, or D. Which type of pain is considered to be neuropathic, meaning a pain caused by your nerves, or a nerve type pain? Is it A, pain that radiates from the back and hip into the legs? Is it pain in the feet that feels like pins and needles? Is it pain that lasts for several minutes after an injury? Or is it pain that feels like cramping and squeezing? Let us know what you guys think. A, B, C, or D? As those comments come in, I will let you guys kind of move on into it. I'll leave the slide up. We're starting to get some answers. But let's talk about diabetic neuropathic pain and some of the things that can happen from it. But it does look like B, pain that is in the feet and feels like pins and needles. So Dr. Kemp, can you describe more about this neuropathic pain or neuropathy and like what can result from it?
Right. So we see this commonly in patients with diabetes, and especially as the blood sugar becomes a little less well controlled. And with neuropathy, we see that you get this tingling, burning sensation. It's usually worse at night. There's a lot of reasons why we think it's worse at night, but patients tend to relate that it feels more noticeable when they're sleeping. And because of this neuropathy, you kind of have a decrease in sensation. And so you're unable to detect things with your feet that you might otherwise feel. And so you're more prone to injury when this happens. We see that a lot of times patients with neuropathy will come in and have sometimes things like glass or wood in their feet, and they have no idea that it's there. So this neuropathic pain and kind of loss of sensation that's associated with it tend to lead to sometimes severe concerns for the feet.
So I think it would be helpful to know, apart from neuropathy, what other things do you see in
Right.
your patients? What are the common foot problems?
Sure.
Let's go to that.
Yeah, I think other than neuropathy, we see a lot of skin changes. A lot of times because of neuropathy, you also get neuropathy of what's called the autonomic nervous system. And the autonomic nervous system is essentially responsible in part for controlling the sweat glands and the oil glands of your skin. So as that becomes more affected, we see that those don't work as well, and they lead to drying of the feet. And so a lot of times as your disease process would advance, you'll kind of notice that the skin starts to get a little more flaky, a little drier. And this can cause some problems because the skin is unable to essentially rebound from injury or concerns. And sometimes it can lead to an ulceration. We see a lot of times there'll also be development of calluses in high pressure areas. And basically a callus is your body's way of making a Band-Aid where it has more pressure. And that's to try to prevent the skin from breaking down. And so unfortunately with calluses, they can not only try to prevent areas of high pressure, but they can also lead to increased pressure in those areas. So sometimes we'll see underneath a callus an ulcer will form. And an ulcer is essentially a break in the skin that is kind of open and takes some time to heal. The problem with ulcers is that they can potentially get infected. And when that happens, we tend to see more complications, including up to potentially loss of limb.
So I think these calluses, I loved your statement, like it's like a Band-Aid, kind of a good thing. But I've seen those patients too, that they think it's just the callus, but then below there is this ulcer, and it doesn't show up there. Patient doesn't have pain sensation. It shows up in some sort of infection in the foot. So calluses help protect things that are due to the friction in foot architecture. Better footwear to prevent them from happening is key. And again, we'll talk a little bit more about that later on. But these things, it's just helpful to know and think about these different problems that you could have as a patient with diabetes. And on my side, I've seen the ill effect of this, and people getting either toes off or half of the foot or below knee amputation. So it's something serious, but I say, well-controlled diabetes is a cause of nothing. So if your diabetes is well controlled, in general, you can minimize a lot of it. What else? Fungal infections of the toenails, more common?
I would say it's more common. You have usually some sort of a decrease in blood flow through peripheral vascular disease. So we see that they have micro and macular vessel disease. So sometimes the small and the bigger arteries in the feet and the legs tend to not work as well. So when you have decreased blood flow to the feet, you'll sometimes have decreased inability for your immune system to kind of ward off some of those fungal infections. So it is a little bit more common in the diabetic patient.
Got it. Other things, any other problems that we should talk about for patients with diabetes?
I think things like ulcerations are kind of the big things. We want to really look out for any new areas of rubbing or redness, whether that's from a new shoe or just walking around your house. If you step on something, all those things can lead to problems down the road that can have serious consequences. It's important that as a diabetic patient, you would check your feet every day. And any time that you would see any kind of redness or new callus forming, you'd want to notify one of your providers as soon as possible so that they can take a look and make sure they don't have some of these other complications.
Got it. You might be answering something for us, so we won't go there. But by the way, Jamie, this is kind of the first time that we had a almost 100% response, or yeah, most people got B. So that is great. By the way, feel free to ask questions. This is all about answering your questions. So if you have something in mind, please do ask questions, and we'll definitely answer those as well.
Yeah,
So,
yeah,
go ahead.
I was going to say we are here to help you guys. So the more questions you ask, we can actually get to the content that you want. We've got another question for you, the audience. So let us know what your thoughts are. Let me see if I can get the slide to work. If you had an ulcer on your foot, what would you do? Let us know. Which of these actions would you take? Would you ignore it? Would you make an appointment with your doctor? Would you talk with your doctor at the next appointment? Would you treat it yourself? Or, you don't know what you would do because you haven't faced that situation, hopefully, before. Yeah, let us know. What would you do?
And I'll tell you, I've seen all variations of this over 17, 18 years of practicing diabetes. Many people have done all sorts of things. I think pretty much I've seen most of this. And so I wouldn't be surprised, but let's see what's coming in.
We've got all B right now. B is the popular answer in all of our questions.
Excellent. I guess today is the B day. Excellent. So yeah, I think the most important thing is to treat it as an urgency or emergency. In a patient with diabetes, you do not want to wait. So my thing is call your doctor right away and make sure you say two things. A, you have diabetes. B, you have a foot ulcer. I mean, and they should get the message that this is urgent, emergent, get you in soon. But let me see, how would you guide people with this
Right.
answer?
Yeah, as soon as you notice that there's something going on, whether that's some redness or a callus or an ulcer, I would recommend calling your doctor right away. The sooner that we can see you and start to treat the issue, the more likely you are to have a successful outcome, and we can hopefully prevent some of those more serious adverse events. So from my standpoint, it's really important to get to those things as soon as possible.
So I have a question. Let's say you're sitting in the doctor's office and you want your feet looked at, and what are some tips that you have for our viewers for that? I've got some things that I've told people besides just asking. Is there anything else that you have?
Yeah, I think at any doctor's office, you should be able to just approach the provider and say, I'm diabetic. Would you be able to do a basic diabetic foot screening? Can you take a look at my feet, make sure there's nothing concerning to you?
Mm-hmm.
Any healthcare provider could point out maybe something that looks a little concerning, and we can kind of address that as we go.
In the past, I do a lot of tag teaming with providers. If somebody's telling me that, I actually tell the patients to take their shoes off.
Yep.
And I tell them to do that even prior to when the doctor or the provider is coming in, because then that prompts the doctor, like, why do they have their shoes off? Oh, they probably want me to look at them.
Yeah, that's a great idea.
Exactly what I was going to say as well. I mean, just be in the room and say, I'll take my shoes and socks off. Because remember, doctors may be rushed going from one to next appointment. They may sometimes think, they may sometimes not think about it. But now when there's this visual symbol of your beautiful feet, then it has to be done. So that's really a great tip. So thanks, Jamie, for bringing that up. And Arnold is saying his feet are hot on the inside and freezing cold on the outside. Thoughts? So I'll let you answer.
Sure.
How would you address this?
Yeah,
The patient complained of that.
I think for me, it's twofold, and I'd have to look at several things that are going on. First, I would check the blood flow and see if there's any abnormalities there. We can do that in a variety of ways, whether that's just in our clinic or we can send you out to get more tests. And we'd also want to do a neurological exam and see if there's any changes with the neuropathy or decreased sensation. Sometimes both of those things can lead to sensations of hot and cold on either side of the foot. I don't know.
So kind of showing it to your doctor. And the good news is that I'll get a free foot exam today. And the good news is you will see what a good foot exam should look like. So I think what Dr. Kemp is talking about will be able to show you. And that's kind of the exam you want. In terms of, yes, it could be either one, blood supply or nerve supply. So that has to be looked into. And this sounds a little more neuropathic. But yeah, so talk to your doctor, get a full foot exam. Cool. So again, if you have any questions, please feel free to And then Jamie, what is your guidance to us now? I think we move to we are supposed to answer a question, which is how to monitor to make sure that your foot and you are not at risk for these dreaded complications. So I'll again let the expert begin, and then I'll chime in wherever I can. So what should patients be doing in general to
Yeah.
reduce their risk?
So the things that I tell my patients are that you want to check your feet every day. And that means basically you want to look at all the surfaces. And so one of the ways that I recommend that is that I kind of brought this along to show you is that you can get what's called a telescoping mirror. And you can kind of move this around a little bit. And you can basically use this to inspect the bottom of your foot like you would underneath a car or something else. And this gives you an opportunity to see if there's anything that's concerning. The other thing would be I recommend wearing white socks. A lot of times, if you wear a darker colored sock, if there's an issue with your foot and say there's some bleeding or some drainage, you may not notice it in a darker color, but in the white sock, it tends to be more pronounced. So sometimes the sock can be an early warning system.
Good idea.
For any kind of open area on the foot or any kind of drainage. The other thing is just routine evaluation. I think it's helpful for any diabetic patient to be seen at least once a year for their feet specifically, and just to have someone take a look and see if there are any potential risk factors that you have kind of going forward.
Now, do you think all patients should go to specialists like you, podiatrists, or do you think there's a role for their own doctor in the exam?
Yeah, I think there's definitely a role for their own doctor in the exam. Pretty much any physician would be able to evaluate the feet and notice if there's something concerning. And if there is, a lot of times we get those referrals. They'll send patients to us to take a look and see if their concerns are something that we need to address early, or if they can kind of watch and wait.
Excellent. And that's my strategy too. I'll do a full foot exam once a year, and then somebody at risk, I may do more than that. And when I see things that I say can make things worse, so let's say redness, let's say deformities that I know when they get worse, bunions, hammer toes, that they will affect the patient, or redness anywhere. So calluses that are more than mild and usual. So I have a low threshold for sending my patients to podiatry. Part of it is simply this. It's not that it has to be done, and at least that exam I do a pretty good job of doing it, but it's really to establish that relationship and then to know over the years how my patient is progressing. Yeah, I'm focused on their numbers, their diabetes, ABC. So I may be not as focused on the foot. So I think having that relationship, when something bad happens, you're not looking for a foot doctor. So in general, I have a low threshold for recommending my patients to have a podiatrist on the part of the team.
Yeah, I think that's great.
Now, I think a few other things you have to think about. Diabetes and barefoot doesn't go along very well. So I strongly recommend my patient not to walk barefoot, even in the beginning of diabetes. But once you start seeing loss of sensation, absolutely. And not even like you get out of bed, you have slippers right there. It's not as if, oh, I'll just go. That's where most of the injuries would happen, is in your own home. So no walking barefoot. Is there certain footwear they should get?
Usually just more supportive footwear is helpful. It's usually a more flexible shoe doesn't give you enough support. And sometimes they're a little thinner, and if you step on something, you may not notice that you stepped on it. So I think a little bit more firm of the bottom of the shoe. And I agree with Dr. Bhargava that walking barefoot is a big risk factor, especially once you start losing the sensation.
Great.
And I was just going to ask that follow-up, like, in the slipper, you want to make sure it's the hard sole type of slipper and not some of the soft sole type of slippers. And something I learned last week, or I think the week before, is there are diabetic slippers. So there's diabetic shoes, but there's also diabetic slippers that you can get. We've got a comment coming in from Tyler, and I think he's saying, I heard that pedicures are good for diabetics. Is that true?
So I tend not to recommend a pedicure right away. And it's just because if you were to have any complications or cuts or anything from that, depending on your overall health status, how much neuropathy you have, what the blood flow situation is, you could have more serious consequences of that. But a lot of times what I'll do is if I do see a patient who is relatively well controlled, I may do a nail debridement, trimming the nails in my office, and then recommend a pedicure after that, kind of once I know that they're in good shape and would know if there's a problem. So a lot of times I would recommend you see a podiatrist for your foot care first. And if they say that it's okay to go to a pedicure, and you have that done, that's fine.
That's good to know, because I think so. For me, what should I be looking at in my patients?
Yeah, I think neuropathy is the big thing.
Okay.
That loss of sensation is
Sure.
usually a red
So-
flag for me.
Okay.
And then decreased pulses.
Okay.
As soon as I notice some decrease in that, then I tend to shy away from sending them out.
Well, good to know. Today I learned. By the way, today I learned is the theme. Remember that at the end we'll be asking you what you learned today. So that was one good thing for me. Like they ask about pedicures, and I say I don't do them, and I'm very agnostic. I don't even get them. So don't do them. Don't get them. But now I know if there's neuropathy or blood supply issue, then you should not get them.
Sure.
Got it. I think the other thing I would. How do they select proper footwear? With your guidance or even without? What do they do? What do you tell them?
So I think going to a lot of times the kind of the shoe distributors that deal with the diabetic shoe tend to understand the fit a little more appropriately. And a lot of times we'll send people specifically to have someone help them with their shoe. If you're kind of doing it on your own, which is reasonable also, you want to make sure it's not too tight so that you're not rubbing on the toes in the end of the shoe. And you also want to make sure it's not so loose that your foot slides around a lot, because that rubbing and sliding can cause blistering and ulcers as well. So it should be kind of snug, but still have some room to move the toes a little bit.
Great. Thank you. One more comment. Several years ago at the fair, someone encouraged me to get free diabetic shoes through Medicare. My regular doctor said I didn't qualify. What qualifies for shoes through Medicare?
Usually there's some documented form of neuropathy and diabetes as well. And so a lot of times it's more of the documentation side and some physical exam findings that we may see in clinic. So that's something that, we'd be happy to kind of see people in any podiatrist office, and we can kind of make sure that you have the appropriate but accurate documentation to hopefully get you the shoes.
So that form that gets filled by people like us. Well, the experts cannot fill that form, unfortunately. There's a reason. There must be some reason in their infinite wisdom. But the point is that there is about 5 things there, and that's previous history of ulcer, foot deformity. And that's the one that I'm able to use quite a bit, because almost all people have foot deformity, but again, certain kind, and then blood supply issues. So their point is it's for the higher risk patient. And I agree with that. Not everybody will see that benefit, and these shoes are expensive. So yes, there are certain criteria, and that's why it's not like it's for everyone. Okay, cool. That's a great question. I'm glad you asked that. So thank you. All right. The other thing I would say is smoking. If you quit smoking, it'll be good for your feet and soul. Soul, S-O-U-L, whichever. It's for all of them, because these arteries get harder. And as Dr. Kemp said earlier, you need that blood supply going there for your immune system, the white blood cells to fight infections. So that's another thing I would say is very worthy of avoiding if you want a happy feet. All right. Jamie, back to you.
Okay, I've tried to put the poll up there a couple of times, and I finally got it in there. So the last poll for our audience: how often do you examine your own feet for changes? A, daily, B, monthly, every 6 months, or once a year? And just tell us what you're doing. Just let us know, how often do you look at your own feet? And not just look at them, but really look at them and examine them. So we've got Cindy doing daily.
That's fantastic.
Holly, once a year. Tyler, monthly.
Got it.
Yeah, so this is great. And we've got Dawn doing daily as well. So a lot of people really motivated to look at their feet. So now we'll kind of talk through, like, what do you guys recommend? How should we be looking at our feet, and how often should we be looking at them?
Yeah, so I think that I would agree with A would be my biggest recommendation. I think seeing the feet every day is helpful, and that you recognize what normal is for you. And so if there is a change or something does get worse, you'll recognize that change as something that's different than what you normally see. And it gives you hopefully an earlier detection of a problem rather than a later problem.
Got it. Yeah, I think, because you described to me, like, one is looking at things. The other is more about taking care of your feet.
Right.
Like, what should they be doing and how often?
Yeah, so I think that a good lotion is a good option daily. I don't recommend between the toes. I think that a lot of times it gets too moist, and there's some issues with skin breakdown. But I think that
That's
just
great.
applying it on other surfaces at least once a day, if not twice, especially as that neuropathy gets worse, the skin gets a little drier.
Got it.
And so I think keeping it lotioned and well hydrated kind of helps prevent some of those calluses and some of the ulcers that we see forming. Again, kind of some of the things we've talked about, looking at the feet every day, not walking barefoot, white socks, all of those things kind of go a long way. Even things like nail trimming. If you're able to trim your own nails, you want to kind of keep those kind of in check. Don't let them get too long, too thick. The recommendation from a lot of the societies is that they're kind of straight across and not curved.
I see.
So that's something that we kind of recommend if you're doing it at
Good
home.
point. Good point. Now, I am kind of hesitant about my patients trimming their nails
Mhm.
if they have neuropathy. Once you
agree.
get it in toe, I'm saying,
Yep.
let somebody else do it for you.
Sure,
Because pain is a good guard against injury, right?
it is.
You cut it a wrong way, and those remaining nerves in that part of the nail would say, yeah, it's too deep.
Yep.
So I'm kind of, again, a low threshold on that.
Yep.
Hey, and the other thing is many of my patients afflicted with diabetes may not be able to reach or see their foot. So then how do you trim your toenails safely, adequately yourself? There are some comments, and there's one that I actually would like to talk about a little bit more. But one person from Facebook said at night they usually apply lotion, and I really like your thought about not doing it in between toes. So thank you. That's good learning for me. Now, can I ask you about what kind of lotion? Because like somebody saying, I use M-Lactin Rapid Relief. So not necessarily brand names, but what are
Yeah.
they looking? What should they be looking for?
I prefer something that's a little thicker, more of almost like a cream or a paste rather than some of the thinner lotions. I just think
Okay.
that they sit on the skin a little longer and hydrate a little better. And I agree. Specific brands, I don't tend to recommend too much. It's just more of if you feel like it's a little thicker of a product, that tends to go a little bit longer of a way.
Many years ago when I was in Wisconsin, and I haven't recommended it more here, very dry feet, we used to say udder's balm.
Mhm.
Is that
Yeah,
something
that's
recommended?
reasonable.
Okay.
Yeah.
Yeah, if it was super dry, then that's what we would do. So something doesn't have to be expensive and doesn't have to be a particular brand and so forth. No, I think just prevention is the key in diabetes. It always is, right? Diabetes is a silent disease. So every complication of diabetes almost is silent. That's why those foot exams are so important. The one that you do and the one people like us do. Very, very important. Some other thing that you want to think about from a prevention standpoint, of course, numbers like sugars, you want to keep them in control. The closer your A1C is to 7 or 6.5, the better your chances start reducing very nicely at the higher levels, and then they start flattening up, but there's always a benefit. One thing we haven't talked about is to keep those blood vessels happy, you have to do a few things. This is kind of the ABC of diabetes, which, by the way, we'll be talking in the diabetes month. So A was the A1C, B, blood pressure, that you want to keep your blood pressure in good control. And we'll talk about specific numbers next time. And also your cholesterol in control. Because over time, these are the things, if you don't control, lead to this peripheral vascular disease, or your big blood vessels in the leg, those becoming narrower and not taking enough blood to your feet. So it's so important that you keep these numbers in control as well. So keep taking your medicines and then go to your podiatrist. So now one thing, and I've covered this from my stance, like when
Sure.
should I send someone to podiatrist?
Mhm.
Let me hear from you. When do you think a non-podiatrist, like physicians, endocrinologists, send a patient to you? Like,
Yeah, I think the first thing is anytime you have a concern, anything
Okay.
with the lower extremity that stands out as concerning or new, we're happy to see them then. For the diabetic patients, I think it's good to check in at least once a year. And then from our end, we can kind of help them with the patient decide what the risks are, what their personal risk level is, and how often they should come see us. And then just anytime you notice any kind of the early onset neuropathy or blood flow concerns, kind of a little bit faint pulses, we're happy to see and evaluate them at that point.
excellent. All right, now is the most fun part of this, which is I get a free foot exam from a university professional. So we will go to that next. For that, we have a pretty elaborate exercise here.
I thought it was funny that you said that you don't get pedicures and yet we're showing your feet on camera today.
Yes, for this I did. No, I didn't do pedicures. No, I did get it once or twice, maybe in lifetime. So, uh, all right, do not judge. So there's no judging.
Yeah.
This is about the procedure.
Oh, this is the best
not
looking
about the
foot I've seen all
itself.
day.
There we go. Thank you for saying that.
Yeah. So the big thing for me is just evaluating first the skin. And so I would start the leg and kind of look and see if there's anything open or rubbing. I would check the back of the leg in the heels while I'm there, look for dryness and any calluses or cracking of the skin there. And then we kind of start at the top and look between the toes, each one, make sure there's no concerns there, and look at the nails. Try to make sure there's no signs of infection and everything looks great here. And then I check the bottom and look for any kind of abnormal calluses or pressure areas that may develop a callus, as well as any ulcers as well. And fortunately, you passed today.
Awesome.
I'll also check the blood flow. We'll just check the pulses in a couple places to see if we can feel it and make sure everything is kind of as expected. That's great. And then a lot of times we'll use what's called a monofilament to check the sensation. And so I have you close your eyes and I'll touch several places and have you identify when you feel it.
Yes. 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 Yes.
Good. And then we also do the
Yes.
seeker at the top.
Excellent.
So you passed. You passed your basic foot exam.
Beautiful, and I'm ticklish, but I
There
tried
you
not
go.
to wiggle too much.
Yeah, you did great.
either. So
Yeah.
I passed my, that test as well. All right, well, let's bring it home. Let's, Jamie, what else you have? Today you have been quiet and silent, so what else you got?
I know I don't have to talk a lot today. It's kind of nice. I got to sit back, not put my feet up on camera. I got spoiled. No, I think this was great. I learned a few tips. I think Dr. B, you said that you learned a few tips. So today I learned about recommending white socks. It makes complete sense, but it's something that I've never thought about before. So I kind of want to hear what are your guys' take-home points from today, and then I can introduce what we've got coming up.
Yeah, so please type in. This is the most important part of this. This whole process of just putting it on writing has significant effect on how our brain remembers things. So we always want people to type in what they learned from today. Kind of like that analogy of callus and a Band-Aid in one sense. That was good. I thought I learned a few more things, but they'll come to me in a moment. Yeah. I must type in too, right?
Yeah.
But I think it was a good reminder, cutting toenails across straight, not trying to get the curves in, because that's where the chances of injury are the most. So that was good learning for me as well.
Yep. We've got some people answering, so I'll kind of highlight them as they're coming in. But the other one that makes complete sense to me as a pharmacist is going more with the creams and ointments versus the lotions. The lotions are liquidy. As a pharmacist, the lotions are made with more water. Creams and ointments use less water, and so they're less drying. So I think that's good. Holly's saying, thanks for encouraging us to examine our own feet. And then we've got another question. What does C stand for, the ABCs of diabetes? Cindy, this is great because this actually leads into what our next topic is. So I can actually share my screen.
Yeah, but in the meantime, let me just say one Facebook user did say, don't go barefoot. I'm glad somebody said that. It's the one above Holly. And check into diabetic shoes. So that's great. Another user said, white socks, wearing shoes indoors. That's one of my big ones. So I'm so glad you mentioned that anytime, just do that. Find comfortable, firm sole things and then use them. And then the thicker foot lotion or thicker cream, so as you say. So, and Holly's talking about the ointment and so forth. So again, any other today I learned, please put them in. But we're getting closer to getting done here. So Jamie, what we got in the store for next time?
Next time, we're not quite going every 4 weeks next time, because if we did that, we'd be landing near Thanksgiving. So we're going to go November 17th, and we're going to be learning our diabetes ABCs. So A1C, blood pressure, and cholesterol. And so we'll have another guest on, a guest from Mason City on this time to help us learn our ABCs. So another good topic.
He has dedicated his life to diabetes as an internist, has a beautiful diabetes center combined with a kidney specialist and others in Mason City. We're truly excited to have Dr. Mark Johnson join us next time, and it'll be pretty fantastic because diabetes is more than sugars. I say I'm helping you control your sugars today and your risk for heart attacks and strokes in the future. And to do those things, you got to get all your things right, the ABCs. So we'll talk about the ABCs and how to track and control all of them. So we'll see you on November 17th. I think we're about to close. Jamie, what you got to say in closing?
No, I'm just excited. Thank you, Dr. Kemp, for coming in. I thought that you did a fantastic job. I learned a lot from you. Dr. B, as always, I am always learning from you. So thank you, guys. If anybody has questions, keep them coming in. We will continue to answer questions after the fact. Have a good day, everybody.
Appreciate it.
For
Thank you.
joining us.
Yeah.
And thank you everyone for joining in our request to change diabetes. So let's change diabetes together and have a great day.